Fab. So it's 15:16. So I think we have the license to get stuck in and get started. So hello and welcome to the final session of our conference today. I'd like to encourage you, if you feel comfortable with it, to pop your video on. It's always nice to see some friendly faces when you're presenting or speaking, and it helps you get a bit of a feel of who's in the room as well. If you've got any accessibility needs, hopefully our team would be aware of these and flag this up with us. We'll do our best to meet those. Closed captions are enabled, so if you use closed captions, then please tune into those. My name is Sarah Sweeney. I'm Head of Policy at National Voices in a maternity cover role for Rebecca Steinfeld. And I am a white female in my 30s with ginger hair down to my shoulders. And I'm the chair for today's session. So welcome to our final session. If you've been with us all day, we hope you've enjoyed the conference. We've certainly enjoyed having you. If you're just joining us now for the first time, welcome. You've picked the perfect session, as we'll be running through the things we've been learning from today across all of the workshops and having our final panel discussion. Without further ado, I'd like to introduce our panelists for today. With us, we've got Sam Ofoegbu, who's a lived experience partner at National Voices. Sam is a fashion designer and retailer and creative consultant and has had her own business for the last 13 years. She recently became a new mum in her 40s to her beautiful son, who's diagnosed with a critical heart condition and Down syndrome at birth. Sam has since been introduced to National Voices to become a lived experience partner and learn to become a coach to system leaders and hopes to make positive changes within health and social care. Sam, thank you so much for joining us today and for contributing throughout all the sessions. You really are a hero. Next, I'd like to introduce Sharon Brennan, who's Health and Integration Policy Manager at Alzheimer Society. Sharon is the Health and Integration Policy Manager at Alzheimer Society. And prior to joining the Society in 2021, Sharon was an award-winning senior correspondent at the Health Service Journal, leading on integration. And I get to share the amazing news that Sharon was recently appointed as a trustee of National Voices. So welcome to the session and welcome to the trustee board, Sharon. We're really pleased to have you on board, pardon the pun, and thanks so much for all of your contributions to National Voices work around integrated care since I joined in January, but I'm sure that went far before I joined as well. With us also today, we have Abdul Hamied. Abdul is Deputy Director for Strategic Partnerships for the National Healthcare Inequalities Improvement Programme at NHS England and NHS Improvement. He's got extensive NHS experience, and prior to joining his current team, he was Deputy Director, Head of Vaccine Equalities in the COVID-19 Vaccine Deployment Programme at NHS England and Improvement. Abdul, it was really lovely to catch up with you earlier this week and to hear about just how many people in your family are part of the NHS and some of your history with National Voices. Until recently, our fourth panelist, his name is William Roberts. Until recently, he was Director of Health Inequalities, Impact and Learning at the Innovation Unit. He led on projects that introduce and scale innovative approaches to care. From the end of June, William will take on the role of CEO at the Royal Society for Public Health. And it takes quite a special kind of person to give so freely of their time when they've just finished up one important job and are about to start another. So William, thank you so much for joining us today. We really appreciate it. Ella, if you could just bring us to the next slide, please. In a bid to try to make a 300-person session as interactive as possible, we've got a Mentimeter. So if you go to the link that is just about to be posted in the chat to the Mentimeter, we're trying to crowdsource advice for ICS leaders. So if you go to that link that's just being posted in the chat any moment now, we'd love if you could answer the following question. So the question is, reflecting on what you've learned today, what would be your key piece of advice to ICS leaders? We're going to bring that all together. We're going to share it with ICS leaders across the country following up to this conference. As you pop things in, they're going to pop up on the screen. So Ella, if you don't mind just leaving that slide open there, and we'll kind of see that trickle in throughout the session. It's my job to give an overview of the key themes that came up through the workshops. So I'll go through those now. So as many of you know, we had 7 workshops that ran twice earlier today, and there's so much learning have come up through them. And so I just wanted to share those. Some of the learning that we heard was that lived experience should be resourced if we want people to work at a strategic level, and that means paying for lived experience input. We hope that this will help to frame the conversations around integrated care systems. We heard as well that people often need an external facilitator or someone to support them to be involved. For example, lived experience leaders like Debbie Dripper, who work with communities to support involvement. they must have skills and time to devote to people using services. Some of the themes that I've heard throughout the conference today include that we shouldn't underestimate the voluntary sector. For example, we heard in one of the workshops about how in one area, the voluntary sector employed more people than the NHS, 14,000 people compared to the NHS's 10,000. And if that isn't people power, I don't know what is. Another key thing that's come up again and again throughout, I think, lots of the workshops and breakout discussions is about the importance of equal partnerships within ICSs, shifting from what can sometimes be a parent and child relationship between statutory and voluntary organisations to an adult-to-adult relationship. We need to put the resource and time into building collaboration. And this does take time, but if we go into this open to change, it can work, and the sum is definitely greater than the parts. In the VCSE Alliances workshop, we heard suggestions of framing VCSE alliances around an inclusion and equalities lens to help focus us all on who is least well served right now, which would then immediately make it clear that we need all partners in the room to make it right. Small and large, grassroots and national organisations all have a contribution to make. We heard as well that we need to flip the script, it's hard to say that, flip the script from why communities are not engaging to what is the system doing to hinder or block people and communities from being involved in decisions about their local services and decisions about their care and treatment. We heard that trust and trusted relationships are critical. Investing in communities requires long-term commitment, and that trust itself is an outcome. We also heard that health inequalities can only be addressed in the long term and at a neighbourhood level, and in genuinely collaborating with communities, this is where resources should be focused. We heard of the importance of providing education and development support to professionals on being members of multidisciplinary teams and how to share those teams. And if anyone has been like me, you probably have seen lots of complex organograms today, each of us trying to share our model of what we think partnerships should look like within integrated care systems. And it feels that they get more and more complex the more actors we bring in, but all the actors are really important to have there. And for me, this drives home a point that things are complex, and it really is an achievement when we get collaboration right. And so we should be proud when we do. It takes effort and it's not easy. And with that, and finalising and kind of the themes that we're bringing out of the workshops, I want to share something that Ian Jones, who was in the Population Health Management workshop, shared. Ian Jones is Chief Executive of Volunteer Cornwall, and he shared 4 principles for collaborative success. The first one was to focus on mission before organisation, to manage through trust, not control, to promote others, not yourself, and to build constellations, not stars. So without further ado, I'd like to pass over to our panel and share the first question for our panel for today. And the first question is, how can we strengthen the role of people, communities, and voluntary sector organisations in integrated care systems? And if it's okay, William, I'd like to come to you first. Thank you.
So I think that, trying to sort of answer that, I think the first thing is to value them, and to actually value that there's something you're going to learn from it. And I think part of the challenge with working in the NHS, I worked there for a long time, is that you have so many different pressures and you forget what you're really there for. And fundamentally, the NHS there is to serve the public. It's not there to serve itself. And I think there's a piece for me about trying to absolutely focus organisations on understanding why it will make such a big difference to them if they listen to people. And I think the other thing I'd say linked to that is to really build on the lived experience that exists within the staff body. So the NHS is lots and lots of people, and many of them have both friends, family members and themselves that have lived experience. And there's kind of a sense at times where people forget that when you're working in the NHS. And I think I was going to say one thing is let's turn it on its head and let's start thinking about how we can really build out from service users rather than building out from the NHS as a service. The very fact that people say, how do we start to engage with the NHS rather than how do we engage with the people we're serving is a really interesting question. And you'd never do that in a business. In any business, you turn it around and wonder, how do you work with your customers, your service users, your constituents first off? And I think that's really, really important. And decide that you have much more to offer than they have to offer you. That's a really powerful position to come from. And I think that's something that isn't seen very much in lived experience. It's seen as a nice add-on by the NHS rather than the essential building blocks of where you start from, as it would be in any other business.
Absolutely. Thank you so much, William. And I really like that. Yeah, NHS is there for the public, not there for itself. And we need to focus on the kind of core business and mission of the NHS. I think, as you've mentioned, lived experience at the end is the perfect time to come to Sam. Sam, can I bring you in to answer the question? So how we can strengthen the role of people, communities and voluntary sector organisations and ICSEs?
Yeah, I would say it is really off the back of what William just said there, just seeing people with lived experience. And it was really important. You did just point out that there's thousands of people who work for the NHS who do have lived experience, as well as people like me from the community who aren't healthcare workers, who have lived experience, bringing them to the fore so you can build reciprocal relationships with them. So, all we want is better outcomes of care for everybody involved. And the only way you're really going to get that is from bringing the people in who the services are for.
Absolutely. Thank you so much, Sam. Really appreciate that contribution. And that's absolutely the truth. And there's so many practical ways that we can weave that into what ICSs do every day as part of their business. And I think that needs to sit within every decision and within every structure and within every conversation, and not sit out in a place externally to reach into. So thank you so much for that. Sharon, can I call on you next, please?
Absolutely. We actually put the people with dementia and their experiences at the heart of Alzheimer's Society. And I think that some of the key lessons we've learned is remember that people with long-term health conditions or any health condition will have other things on their plate. And quite often they'll be fatigued or trying to do other things. So when they're engaging with you and trying to support and kind of improve lived experience and pathways that come from that, do value that experience. So be really clear as to why you've invited them to do something, what contribution you want them to do, and make sure that you feed back so that people understand how they helped. I think otherwise kind of the goodwill will burn out. There's other thing I'd also like to mention is that there's now a requisite that ICS's lived experience panels and their engagement reflect the communities in which they're based. And I think we have to do a lot more to ensure that we are enabling people from ethnic minority backgrounds or from more maybe working class backgrounds to take part. That could actually come down to payment. Quite often people are not involved because they've got multiple jobs, especially with the cost of living crisis at the moment. Are we helping people? Is a lack of payment a barrier to taking part? And another thing can be to do with training and upskilling. Obviously I'm comfortable speaking in public. I believe that I have something of value to say and that people should listen. That's not a natural place for people to sit. And how do we make sure that people feel involved so that they feel they have a right to be heard and actually want to contribute? So I think there's something around upskilling and payment, and to kind of think again about how we widen participation so it's not the same voices. But without a doubt, don't take that participation for granted, and that has to include feedback on what they did and how that helped.
Absolutely, thank you so much. And I feel that you're beginning to touch on a point around inequalities, and Abdul, if you wanted to come in on that point.
Thank you, Sarah. I think just going back to my very recent experience, actually, as the deputy director within the Vaccine Inequalities programme, we saw very clearly the disparity in the take-up of the vaccine amongst our underserved communities and our deprived communities. And what we were able to do very quickly was to work with the so-called trusted messengers or anchors that are deep rooted in the communities that have strong relationships and trust. And we used the faith leaders and the faith institutions to help us spread the message. We use community leaders and community organizations to help us spread the message and also make their facilities available for various aspects of the vaccine program, including vaccine clinics. And of course, we had the local community volunteers that were significantly playing a huge role, both as volunteers and as community champions, to help us encourage, build confidence, tackle hesitancy, spread the message. And we found that to be really helpful and successful in helping us reach our homeless communities, Gypsy Roma travelers, the asylum seekers, as well as obviously our settled ethnic minority communities. So we really recognize the importance of having the trusted messenger being a key component of delivering our trusted message. And we've seen over the years the lack of investment has meant those community development structures that used to exist quite strongly in local authorities have disappeared. And therefore, for the NHS simply to turn on a switch and expect the community connection to be there at a time of the pandemic and emergency just wasn't going to happen. And without the support of our community leaders, faith leaders and volunteers, we would not have been able to reach the number of people that we've been able to reach and the diversity of people that we've been able to reach. So I think for us now, it's important that we build on that momentum, that we've been able to mobilize the communities. We need to build on that trust, keep the engagement going, broaden it to non-emergency services, so build them into our consultation, service planning, service reviews, and forward planning in terms of prevention agendas. And then ensure that that trust isn't seen as tokenistic and as a one-off. It's seen as a core part. I think, as Will said earlier, it's got to be a core key component of everything we do, rather than as a bolt-on or an add-on or as an afterthought when someone does an equality health impact assessment or challenges some weak aspect. So I think for us, it's got to be at the heart, and they've got to be seen as a partner. And especially as we move into integrated care systems, that partnership is going to become even more important, and therefore that it's essential that it's seen as a key component. It's got to be resourced accordingly to support that relationship building. It can't be added on to an existing comms and engagement job, because it isn't simply about comms and engagement. It's about relationships, it's about building trust, and it's about harnessing that lived experience that people bring. So I think that the key challenge for us is to see the community voluntary sector as a key partner in our forward planning and our strategy and our structures.
Absolutely, and as you say that, it brings to mind what Matthew Taylor said in this morning session around traditionally the NHS has looked at engagement like a date rather than a marriage, and with a date you go along, see how it goes, try it out. If it doesn't work out, you don't go on another date. Whereas local authorities had traditionally looked at it as a kind of longer term sustainable sort of thing. But also it makes me think as well that given that it's so relationship based and you're talking about trust and things as well, then not many of us would keep in touch with a friend who only contacted us when they needed us and didn't see kind of a mutual and kind of beneficial part of that relationship, which kind of leads me to the next question, which is for Sam. And this question has come from Cam Worvin. So just trying to understand a little bit more about your motivations and things as well. So as someone with lived experience, Sam, what do you want to achieve by learning more and engaging with the healthcare system?
I'm really new to this in terms of being a new mum within the last year, who's in her 40s. I'm a Black woman in my 40s, new mum with a child with disabilities. And so because I represent so many communities, I just want to make sure that I can learn as much as possible so I can represent the communities I come from. So being able to build relationships with leaders, and that's where using this lived experience and national voices and bringing me on board to do the training for coaching and mentoring, I think is really important, and how I'm going to kind of be able to get more of closer a seat at the table to be able to ask the important questions to system leaders to make positive change, because it's kind of been a baptism of fire for me when it comes to all the things that have come about in the last 12 months or 24 months since becoming a mum. And so I've had to learn a lot straight away, really fast. And it's just making sure that I'm in a position by learning more about the healthcare system to make better choices for me, for my mental health, so I can make better choices for my son, Theo, and with his disabilities, and make sure that he as a person is at the fore and not just statistic within the Down syndrome community or the statistic within having a congenital heart issue. It's like, if you hear a real person's voice, then you'll get to see more of what's needed within that. And I was seen as someone, or kind of from a demographic who may well be hard to reach, being from an immigrant community, and I haven't been hard to reach because I've been found by National Voices, and my voice has now been getting heard. So I just hope that I can be in that system to be able to keep this sustainable, make more people be able to come through who have voices from different communities, so you can the resources or the money's there to be able to invest in volunteers and carry on doing some good work.
Absolutely, and I totally agree with that. And I think the term hard to reach is so outdated, and it does kind of display a little bit of some of the framing and where that's gone wrong with engagement in the past, and with building those relationships, I think, as well. So thank you so much, Sam, for sharing your experience there. I've got quite a big question now that's coming through. Eamon Dunn has submitted it in the lead up to the conference. And I think we could probably each of us write long essays or do long speeches about this. But I'd really, I would love to understand. I think from my perspective, lots of the decisions made within health and care would look radically different if they were truly made by people with experience of ill health or experience of disadvantage, and the carers of people who live with ill health, and we might see a very different health and care system if that was the case. And so my question really with that is the background context. How can we ensure that there is a truly integrated and person-centred approach? And how can we ensure different health and care services collaborate, cross-refer and share learning, just coming back to how that feels for an individual when they access health and care? Sharon, do you mind if I pick on you for that one?
Absolutely. So 2 parts to that. Was there one about how do we make sure that care is personalised, and how do you share best practice? I would recommend, and obviously I would because I work for the VCSE sector, that the VCSE sector has innovation and it has an understanding of people who experience that condition and what they actually want. Quite often, I've done previous work for the Cystic Fibrosis Trust because I have CF myself, and there was this very kind of bizarre agreement that people with CF just shouldn't have children. And I was pointing out to them, well, we do have children. There's loads of us who have got children, not me, but friends. And I was like, so quite often what you think is acceptable as a risk is very different to the person with the lived experience. So we actually need to be asking people what they actually want and need, and not make that presumption of kind of how people should or shouldn't live their life with health conditions. I think creating a personalised approach is hard. I think integration can do it better. I would involve the VCSE sector from the start though, because we have that lived experience and we have that expertise, and quite often we know things that we're just not being asked about. In a previous breakout session that I was in earlier, someone talked about the respect that people have for the VCSE sector, and that sometimes people don't realise how data rich we are and how experienced we are. And I would say definitely bring people in at the start. There's some good examples that we're doing where we're trying to kind of define pathway working from pre-diagnosis to end-of-life care. And actually a lot of that does involve having that individual dementia advisor, support worker, or whoever that health condition might be, to ensure that people can access the support they need that works for them. And I think without kind of that linking role that the VCSE sector can provide, it's very hard to provide personalised care, because it's very hard for a GP in 10 minutes to be like, well, what can I give you that is right for you? So I think that's one example. In terms of sharing best practice, the problem we have is ICSs are completely at different development stages and they're focused on different things, which is, fair enough, because I know everyone wanted to kind of be able to commission to their own pathway and to their own population needs, but it does make it really hard to influence. We are going out to all ICSs recommending various things to do with dementia, specifically around the governance. So we think there should be someone who is held accountable for dementia in an ICS, which for us is a wide ask that can then be adapted. But best practice is really hard to share. And I did in a previous conversation with someone talk about networks and how important they are. And quite often I think people do rely on clinical networks or face-to-face meetings or someone that they've spoken with. And I would encourage NHS England to work out how better to share best practice and how to find it. So we're in that process at the moment of trying to think, what does good look like for integration with dementia, and trying to kind of unearth that work. But I do worry that we will end up having 42 ICSs reinventing the wheel 42 times when actually there's no need to. What are the best 3 or 4 ICSs that are great at dementia, and how can we share that work? And obviously that will be the same for other conditions. But it is a challenge, and one that I would think should be solvable, because my old job as a journalist, I always wanted to find out what was going wrong. But it should be easy to find out what's going right because people want to talk about it. So I think there is something there about how that's done, and a challenge back to anyone from NHS England on this call. VCSE can help with it. We're not sure, how to spread it. So yes, do use us.
Thank you so much, Sharon. And the point that you made around we know things that we're not being asked about really resonated with me, and around the lack of awareness of the data that the voluntary sector holds. And in the population health management workshop, we heard about some of the really clever ways that Parkinson's UK are working to use data to inform decision making. I'm conscious as well of lots of the really detailed analytics that Citizens Advice produce about the types of issues that people are experiencing, and the type of support that they need with those, and that's really useful and intelligent data coming from the voluntary sector. But I'm aware that almost every organisation on the call will have gold mines of data and information and insight that are probably not used as widely as they could be, and I'm sure there's ones that I haven't heard of before as well. So thank you so much for your input there, Sharon. That's really brilliant. William, can I come to you next on that big question? I'll repeat it to see you have it fresh in your mind. So how can we ensure there's a truly integrated, person-centred approach, and how can we ensure different health and care services collaborate and share?
So start off by actually being really clear about why you're working together. Most integration is a load of old rubbish. People say that they want to work together and they hate each other, and they're saying it because somebody told them they had to, because it's the latest zeitgeist. There's loads of great examples where people work brilliantly together, but it's because they have a shared reason to. And if you base that around service users, real people and people with lived experience, that's a great reason to work together, because you're all trying to get the same output, which is for that person to have a great life. The second thing I think is do what you actually know works. So the people who have made integration work, all the evidence that says integration does work versus the huge evidence that says it doesn't work, all of them have been really clear about the fact that integration will add value. Not everything needs to be integrated. If I'm having my tooth removed, for example, in a dentist, I do not want an integrated care system. I want a really good dentist. I don't need an integrated dentist that talks to everybody else. I just want my tooth removing. And I think that piece about making sure that when integration is there, it is because you need to work together to make it work properly, not because you've been told to work together. And then the third thing is, I think you find three sets of people. I think you find your amplifiers. So they're the people who can give voice to others who don't have it. National Voices amplify, others amplify in that system, but find the people who will amplify and share your voice really widely, because you're going to get really tired if you're the only person saying that all the time. It's exhausting. The second group of people is your translators. It's almost impossible to work with people when you don't understand what they're saying. So find people who are bilinguists, trilinguists, who can talk across NHS jargon, local authority jargon, central government jargon, and human. And if you can get somebody who can do that, that's really amazing, because they can actually try and bring you closer together. And then the third group of people you need to find is bridges, people who are actually really good at getting people to work together. Most people aren't very good at working together. Actually, they're really brilliant working on their own. And so we try to make them better at it when actually it's just not their skill set. And what we really want to do is find those people who really bridge between different groups of people. And they are amazing. And when you find one of those, and you'll all know one of those, don't let go of them. And the other thing to say, it's really interesting, is those people don't ever get moved on in the system. They pretty much stay forever. I'm going to say this now, integrated care systems will last about 6 to 7 years, because that's true of every NHS reorganisation that's been done centrally. If you look at the best places that work together really well in service of the people they serve, they've been doing this for 25, 30 years. And so all these great examples, trailblazers, pioneers, vanguards, front runners, anything that's faster than the rest language, all of them have been doing the same thing for 30 years and changed the badge. And that's the dirty secret of integration, is stick with it, keep doing it, find some decent people and do what you know works.
Thank you so much, William. That's such a good point, all of those amplifiers, translators, bridges. I really like that framing. I know that our comms team will be busy mining for quotes for the end of conference report, and I think we probably will struggle to use the one, most integration is a load of old rubbish. But it's certainly true. It's very difficult to collaborate. If anyone has ever had the experience of trying to work out a time and a place to meet with a group of friends in the group chat, we realise that without lots of really good processes put in place as humans, it's very difficult to collaborate and organise and get them online. So there's no surprise why we're finding this difficult, and it's refreshing to come together and just to speak about that and share our learning. Thank you. And so with that, we'll come to the last question for the panel for today's session. And Abdul, I'd like to come to you first, and I'd be really interested in hearing this from the Inequalities perspective. What would your key piece of advice be for ICS leaders? Oh, Abdul, you're on mute.
That is the million-dollar question. I think for us really is, we need leaders to be genuine, true leaders in this space. They have a privileged position to bring together the collaboration, which needs to be inclusive of all the relevant partners, to support that integration agenda where it makes sense. Taking on point William's point, we don't need everything to be integrated, but where things can be integrated based on the needs of our populations, making sure we have the appropriate data that helps us understand the needs, use that data to form insights, and then use that to drive improvement in service delivery and experience and outcomes. And I think for us, that's going to be a key component, but equally to be prepared to make the hard decisions. I mean, I was talking to a couple of ICS leaders or chief executives that are due to take up their roles shortly, was that they will have to think about their resources, their limited resources, and how those resources need to be prioritized, and how do they need to be prioritized to help address some of the inequality, the inequity agenda. And that may mean some parts of their system not getting a universal offer, because it's always easy for us to say, yeah, let's give something to everybody, and that's equality and fair. Well, no, we know there are groups, we know there are communities, we know there are young people, the elderly people who've got greater needs, and we need to be able to flex the resource in order to respond to those needs and to make sure that those outcomes and experiences are helping us narrow the gap. And I know my boss in the national team, Bola Ovalabi, uses the language, we do not want to just see the ceiling raised, we want the floor to be raised. So therefore there is no inequality within those integrated care systems, especially in areas where deprivation is quite high, or there are groups that have got significantly worse health experiences or worse health outcomes. So we need to be able to prioritize that. So I think for leaders is to be brave, to make the difficult decisions, but more importantly, to take their communities and their partners with them.
Beautiful, thank you so much. And I can just see in the other part of my screen, the responses coming through from the Mentimeter, and they echo some of the things you're saying. It's not an easy job, is it, to be a leader of an ICS? And there's lots of things. So being able to prioritize, being able to be brave, and yeah, bringing people in communities, a great piece of advice. Sharon, could I come to you next? And can I just ask for you to keep it just really short and punchy and brief, just as we come towards the end of the session now?
First key recommendation is involve the VCSE Sector Alliance from the start. Don't start reconfiguring pathways and then coming to us at the end for us to then have to unpick them. And if you're going to use people with lived experience, be really clear what you want from them, why you've asked them, and what the outcome is, and give a date when you're going to come back and explain to them how their contribution made a difference.
Yes, that reads like a manifesto, Sharon. Thank you so much.
You told me to be brief and to the point.
It's perfect. It's perfect. Thank you so much. William, over to you to answer that question. So your key piece of advice for ICS leaders.
Find the people that need you the most and find the people that know them the best.
Perfect. Beautiful. I think you might have all prepared responses for this because it all sounds very profound. Thank you. And Sam, last but not least, I think it's only right that we give you the final word on this, as you've been part of both of the panels and you've also done 2 workshops today. But yes, what would your key piece of advice be for ICS leaders?
Well, I'm very new to this, as I mentioned earlier. And so I just have to think of my personal background being in business and making sure that I reach out to the community to know what the community or what my customers want and need as a shop in their community. So that's the only way I can kind of process that in my head, to say, these leaders need to make sure that they are really in touch with the community and their needs, and make sure that we're at the fore with everybody else to help make those decisions that are, that's as punchy as I'm getting.
Thank you so much, Sam. That is perfectly punchy for me. There's a strong theme there, working closely from the get-go with people, communities, and voluntary sector organisations. Being brave, we know that the job you have is not difficult, is not easy, sorry. And I guess we're all there to support, just by the fact that we're here today. Ella, can I ask you to bring up the slide with the Multimedia Responses, and we can just have a little look at what's coming in. I say to Ella, who's been beautifully juggling all of the different pieces today. Thank you so much. So yeah, we can see some of the pieces of advice coming in through here. Keep patient experience of what you're planning at the front of your thinking about the plan. So echoing your words, Sharon. Recognise and listen to the expertise from your voluntary sector colleagues without seeing them as free labour. recognise the size and complexity of the voluntary sector, appoint a leader for VCSE alliances or organisations as soon as possible, and resource them to build relationships between the two sectors. And I know that one of the themes that came out of the workshops, the VCSE Alliances workshop, was just being able to get in contact, and we're really grateful to our NHS colleagues for saying that they're imminently going to publish a list to make that easier, because we know that's quite challenging for lots of the national organisations particularly. Working with the voluntary sector and people with lived experience as key partners rather than tokenistic ways. Ensure you have access to the voices of all stakeholders, however complicated this might be. To invest in the third sector, the voluntary sector contribute to the VCSE Alliance, and that's VCFSE, so that's including faith organisations who sometimes get missed out of that acronym, who given power to vote on representatives to contribute to the ICP. So yeah, it sounds like maybe there is a bit of consensus and some kind of common threads that are coming through from our discussions today. So with that, I'd like to move just to the final section of our day. First of all, I'd just like to say thank you so much to our panelists for today. Sam, William, Sharon and Abdul, you've been fantastic panelists, and thank you so much for letting me pick your brains and ask you difficult questions. That was all really helpful and really useful, and I think it also shows all the different perspectives each of us come at, being from different organisations and just being different people from different walks of life as well, and all the different things we have to contribute and the different values that we bring to integrated care systems. A day like today wouldn't happen if the team hadn't worked incredibly hard, and if we hadn't been helped by the generosity of a huge number of people, and there's probably too many people to mention them all here. So first up, money makes the world go round, and we've had some very generous funding from the University of Birmingham and the Policy and Innovation Research Unit. Thank you so much for keeping the faith throughout, Robin. We really appreciate that, so thank you, Robin Miller, particularly. I'd like to thank Francis Newell, who Charlotte described earlier this week as an all-round good egg, from the NHS England System Transformation Team, and Nick Gitcham from the NHS England Social Prescribing Team. We know that you've both supported the conference through your time and by making small grants available, and this is really helpful to us, and we're really grateful. Then we need to thank everyone who spoke and who led a workshop. Samir Ben Omar, Andrew Fenton, Rachel Watts, Robin Miller, Kate Joplin, Amy Cole, Ruth Hudson, Christina Jones, Ken Worvin, Alex Boyes, Sharon again, Carrie McKenzie, Lydia Warden, Asma Salim, Agato Pacho, Gary Brock, Debbie Draper, Helen Hassel, Richard Chapman, Isaac Samuels, Maddie DeForge, Matthew Crowther, Andrew Gardner, Laura Reid, Simeon Nichols, Lewis Connell-Smith, Helen Little, Simon Prethme, Ian Jones, and I'm sure that I've missed someone, so if that's you, thank you. I'd like to thank our panelists also from this morning, Matthew Taylor, Robin Miller, Rubina Ahmed, and Sam Ofoegbu. Sam again, getting a shout out there. Sam, you've helped us to focus on lived experience, and we know that you've been supported and coached by our very own Ken Worvin. Thank you so much for giving so freely of your time just today, we really appreciate it. I want to thank our communications team, who I think lots of you will have received some frantic emails from at kind of critical points of the moment of the day, pulling things back together. It's not easy running an event this size, and we're only a small team of people. And Lucy and Rosie have been absolutely heroic. You've worked extremely hard, and we're so grateful to you. The whole show was pulled together by our amazing Ella. Ella, we promise we won't do another big event this year, and we owe you one, and you've done an absolutely incredible job. We are so grateful. And finally, for all of you who've attended, you submitted questions and case studies, and you contributed with generosity and insight to all of our workshops. It's so amazing to see just all the incredible work that's happening across the country. And when we always come together at these events and we discuss the challenges we're facing, we've made such progress over the last 10 years. And there's so many beautiful examples of really important work that's happening within integrated care system patches already. So we can only feel excited about what's going to happen from the 1st of July onwards. So just keep up the good work. We really appreciate it. And given that I've managed to finish 5 minutes early, we have a request from you, and that's that you'd spend those 5 minutes filling out the feedback survey for today and giving us your feedback. Let us know how we've done. There should be a link in the chat any moment now. So that's all from me. Thank you so much, and have a lovely rest of your day.